এটা কারা প্রেজেন্ট করবে এফসিপি মানে
তুষার ভাই কই? Dear moderator, you can start your talk.
Tushar, are you there?
Sir, probably Tushar bhai network problem করছে।
আচ্ছা ভাই আপনি শুরু করেন।
স্যার আমরা কি শুরু করব?
হ্যাঁ তুষার শুরু করো।
হ্যাঁ।
আমি থেকে খুব সুন্দর দেখতে।
Assalamu alaikum and good evening, dear physicians and participants. Welcome you all in today's program. This is the 51st lecture series organized by Ecg Study Group, and today we have among us Assistant Professor Dr. Sharadindu Shekhar Roy from National Institute of Cardiovascular Diseases. He will discuss case-based ECG. So before starting the program, I'd like to announce exciting event which will happen in October. We request our participants to send us real-life ECGs with a short history and 2 differential diagnoses. The ECG should be scanned and then sent via our email. The last date of ECG submission is 30th September, and the best 10 ECGs presenters will be on our show on October. So, dear participants, please try to participate in this program and make it an exciting one. And there will be also some fabulous prizes. So I request Professor Abdul Chowdhury sir to introduce Dr. Sharadindu Shekhar Roy and talk a few words regarding our upcoming program, and then we start the program. Wadud sir. Wadud sir.
Assalamu alaikum and good evening everybody, and perhaps good morning to Aziz Bhai and Rafique sir, Hafiz Bhai as well. To our Nepali friends as well, good evening. Today we are going to have presentation from Dr. Sharadindu Shekhar Roy. Sharadindu was our student, very devoted, and sometimes we have to say that don't study too much. Take a little bit of off time to enjoy life. He's like that. But it seems that his main pleasure is starting. And ECG is one of the main attractions that he has shown all through his clinical training period. I hope today when he is going to present the case-based scenarios, ECGs, we'll be finding out how he approaches to the patient and how he gets pleasure from interpreting and deciding the course of treatment for a particular patient. Dr. Sharadindu Shekhar Roy is one of our youngsters who has particular affinity for ECG interpretation, ECG presentation, and in-depth analysis. Let us together enjoy his glorious, brilliant presentation. Thank you, everybody. And now the theater is open for Dr. Sharadindu Shekhar Roy, Assistant Professor at present National Institute of Cardiovascular Diseases.
Respected course directors of the ECG study group, the moderator and coordinator of the group, respected my teachers and delegates and all the participants, very good evening. It's my immense pleasure to be present here today with an opportunity to present something. First, I would like to request you all to allow me as an intern learner of this platform. With a view to discuss 3 cases, I am starting. My first case, Mr. Y, 46 years old businessman, visited outpatient department for health checkup. Along with routine investigations, an ECG was done. And this is the ECG was found for reporting. Is it normal or deviation from normal? We can see the rate is 90 beats per minute. Rhythm is sinus and regular. PR interval normal, QRS morphology normal, and no ST segment deviation. But T-wave inversion in lead 1 and AVL with negative deflection of the QRS complexes. Is it right axis deviation with high lateral mitral infarction or ischemia? But there is P-wave inversion in lead 1 AVL with positive deflection of the P, QRS, and T in lead AVR. Is it limb lead reversal or dextrocardia? There is normal ROA progression in all chest leads. So dextrocardia excluded. So the ECG diagnosis is limb lead reversal. But which limb leads reversal taken place in this ECG? Changes found in lead 1 AVL and AVR. So it is right arm, left arm lead reversal. How can we report this ECG? Without reporting, should we advise for repeat the ECG? Or can we report as right arm, left arm lead reversal, or right arm, left arm lead reversal with normal ECG findings? In this subject, we got the patient and we requested to repeat the ECG in the ECG laboratory. And the repeat ECG was done in the ECG lab and it was normal. And to see some deviation from other reversal between 2 lower limbs, what will happen or what may be happen, we have done ECG doing this in the ECG laboratory and got this ECG by reversal of the 2 lower limb leads. And it was finding normal ECG findings. And it was actually normal with both lower limb lead reversal, as because with reversal of the lower limb leads, Interventional triangles is preserved as the electrical signals from each leg are virtually identical and does not make any difference with this interpretation. Another ECG limb lead reversal we made in the ECG laboratory and got these findings. Here we can see lead AVL is unchanged, but lead 1, 2, 3 and AVF are all completely inverted, with lead AVR is upright. In case of lead 1, 3 and AVR, 1, 3 and AVR, AVF here switch places. So it is right arm and left leg reversal. Here interventional triangle rotates 180 degrees vertically around an axis formed by AVL. So only lead AVL is unchanged, with lead reversal signs are seen in all other limb leads. May we proceed for second case, sir?
Rafique sir,
Yeah. Can I make a quick comment?
Yes, sir.
So when you get that first ECG, what we do report, we say suspect arm lead reversal, and then we will say interpretation assumes no reversal. And then the final conclusion will please repeat the ECG. Because it is also possible that's the correct ECG, right? So that's the way it is reported, that the first line will be assume arm lead reversal. And then we write interpretation assumes no reversal. And then final conclusion will be please repeat the ECG without making, that's a better way of doing it. Because sometimes you'll find the ECG after patient has gone home. Thank you. So I think you did a great job with this ECG, especially you did this recordings. And for the audience, that one of the things that what he tried to present, give it a little bit of thinking process when you see this kind of reversals. It becomes very difficult when it becomes arm and leg lead reversal. And I had a case where my technician did ECG perfectly all right. What she did not notice that the ECG electrode says right leg, but when it was connected into the machine, that was reversed. So the reversal did not happen in the lead placement. Reversal happened in connecting the ECG electrode to the machine itself. So please keep an eye on that also, please. Thank you.
Thank you.
Can I make a comment?
Yes, please.
So look at the lead one, almost flat line. Whenever you have a flat line in any of the limb leads, assume that there has been some lead reversals between leg and upper limb. You will always find that. And this is very important that you have to review the ECG and repeat the ECG. Because if there is reversal of leads between leg and upper arm, there can be some bizarre changes. If you're not aware of this, there may be inferior MI can become lateral wall MI. That's very important.
May I proceed for second case, sir?
Yes, Sharadindu. Yes, go on, please. It was very nice.
Thank you, sir. And my second case, the ECG tracing of a 40-year-old lady. Here we can see rate is 45 beats per minute. Rhythm is sinus and regular, but P wave is flattening, and the T wave is tall and peaked, and it is more than 12 millimeter in V4, V5, and V6. And in V4, V5, and V6, there is half strength ECG, and QT interval is prolonged in this ECG. It is about 800 millisecond, that is 0.80 second. What is the problem with the measurement of QT interval in an ECG with bradycardia? Does it give the accurate information about QT interval? The normal QT interval, we know that 350 millisecond to 430 millisecond in normal heart rate, and it shortens with tachycardia and it lengthens with bradycardia. So QT interval should be calculated as corrected QT by the Bazet's formula, and the formula says that the QT interval divided by the root over of the RR interval. And why the QT interval calculated as corrected? The QT interval is corrected for what it would theoretically be at a rate of 60 beats per minute. And in this ECG, we calculated the corrected QT interval, and QTC was 0.68 second. That means it is prolonged. So the key points of this ECG is sinus bradycardia, flattening of the P waves, tall peaked T wave, and prolonged corrected QT interval. If we find the causes by step, the tall peak T wave causes are hyperkalemia and hyperacute MI mainly, and causes of the flattening of the P wave is hyperkalemia again, and causes of the prolonged QTC is hypocalcemia and some drug effects, hypothermia, hypertrophic cardiomyopathy, complete AV block, torsity pointis, and congenital long QT syndrome. But in this ECG particularly, if we can correlate with all hyperkalemia and hypocalcemia, findings are more consistent with this ECG. And if we correlate with hyperkalemia and hypocalcemia in this ECG, we may suspect clinically as the patient is suffering from uremia. And real story we found behind this ECG was Mrs. X, 46 years old, a non-diabetic and hypertensive lady, got admitted into hospital through emergency department with the complaints of shortness of breath, drowsiness, and vertigo. And soon after doing the ECG, urgent blood sugar, serum electrolyte, and serum creatinine was sent, and the report revealed normal blood sugar, but serum potassium showed 7 millimole per liter, and her serum creatinine was found 15 milligram per deciliter. And this patient was then immediately referred to the Department of Nephrology, giving the treatment of hyperkalemia. And this was about my second case, sir.
Can you go back to the ECG, please?
Yes, sir. Yes, sir.
So I have just a few comments. One, when you see this kind of ECG, first of all, please look at the calibration, whether the calibration is right or not, because it is low voltage in some leads. Second issue, when you see this QT prolongation, you can always consider, oh, was this ECG done at a double speed? But if it is double speed, then the QRS will be wider. So these are the quick thinking process that must go through your mind. And one of the participants asked the question, T is inverted in V1, V2, V3. Can you call it tall peak T wave? Sure, you can. You don't have to have tall peak in all leads. So I'm sure if V4, V5, V6, if it were normal calibration, you'll look much taller. So those are the few issues that must go through our mind when we are reading this kind of ECG. But this is an excellent ECG because the other thing that you have to consider is the long QT syndrome. And of course, you mentioned about the correction of the QT interval. So thank you.
Ajit, would you make a comment about it?
One question is, sir, what is the P wave?
The question, who is going to answer the P wave question?
I'm Dr. Shafique, sir.
Shafique,
yes, sir.
Sharadindu, what happened to the P wave?
Sir, here P wave is almost flattening, but if very carefully we can see the P waves in the lead too, but it is almost a flattening type.
Yeah.
And
Dr. Shafique, any comment on that P wave?
No, it's okay, sir. I have seen the P wave here. It is clearly seen, but it is very difficult if someone not look into deeply. It's very difficult to get the P wave here. Sir.
Yes, sir.
One of the things that happens with with hyperkalemia, conduction changes. Yes. And it also changes the conduction in the sinus node in the atrium. And a lot of times, two things happen. One, P wave becomes so flat that you can't see it, or maybe there is no conduction of the sinus impulse into the atrium, and you have junctional rhythm. So both things can happen with hyperkalemia. Aziz was about to say something.
Also, you can see the P waves like 1, 2, 3, but definitely the calibration that Rafique sir mentioned is halfway almost compared to the top one EKG, because it has to be 10 millimeter voltage. But definitely if you assume that it is half of that, so it should be P wave could be visible a little bit, but the explanation Dr. Rafique Ahmed gave, definitely that's the right thing to think about in that direction when hyperkalemia is significant. but calibrations definitely is a problem. I'm not sure how in the same ECG, the two calibration there. Or it was done in different time.
But because Ajay, this is not a machine like ours. This is done, you have to choose the electrodes 3 at a time.
Yeah,
and
I see
you can
that.
individualize the calibration also.
Mm-hmm.
So why are we wasting so much time on this thing? Is it important? It is actually. That's why we are waking up our brain and making us think, and not thinking of a diagnosis, but thinking of a diagnosis along with differential diagnosis. So that is the whole point of clinical medicine. If I get focused on one diagnosis, I am going to be wrong most of the time. And we can't be, and that is the beauty of medicine, or the pitfall of medicine, that we cannot bog down with single diagnosis. We have to come up with one diagnosis and then go through the differential diagnosis, come to a final diagnosis. Even then I can be wrong, and I have to keep an open mind on that. Thank you.
And I have one question, Dr. Roy. Was the patient seen in the office or in the hospital, in the ER?
Thank you, sir. This patient got admitted into the coronary care unit, basically, coronary care unit, sir.
So I think what important is management of this patient, okay? Because how much delay is going to have to get a nephrology consult, evaluation, and all these things. That's the point I'd like to make. It's an emergent situation. And if you see that potassium is 7, we have to start some treatment right away in the coronary care unit. You can call nephrology consult, but our job is to really correct as much as possible, in the direction, mobilization of potassium, inside the cell with certain bicarb, calcium chloride, and some potassium binding reagent. Because otherwise, as long as we delay, the patient might have sinus wide open, wide complex wave and go to cardiac arrest. So very important management, quick management, not to wait for the nephrology to come. I think we need to start treatment right away.
Yes, sir. Yes, sir, we did it. And we did the management of hyperkalemia first immediately.
Thank you. Next ECG, please.
Thank you, sir. Thank you, sir. And then my third case, Mr. Y, 43 years old gentleman, is a smoker and dyslipidemic. He is not hypertensive and non-diabetic. He has a positive family history of coronary artery disease. He was advised for exercise tolerance test as an outpatient case for evaluation of chest discomfort. His baseline ECG, chest X-ray, and echocardiogram was normal. This is the pretest ECG in the ETT laboratory. Let us see, the heart rate is 70 beats per minute, blood pressure 120 over 80 millimeter of mercury. Maximum predicted heart rate calculated in this subject is 180 beats per minute, and target heart rate was calculated as 152 beats per minute. And this is the stage 1 exercise ECG tracing, where we can see heart rate is 142 beats per minute, but the blood pressure response is normal. Patient had no symptom. On query, he felt no fatigue also. And the ECG was showing sinus rhythm with broad complexes QRS of more than 120 milliseconds, slurred R wave in lead 1 AVL, slurred S wave in 2, 3 AVF and V5. T wave is opposite to QRS complexes in all leads with left axis deviation. All features are consistent with left bundle branch block. What should we do? Should we stop the test or to continue? As the patient had no symptom and he is tolerant to exercise, stage 2 was proceeded. And this is the stage 2 exercise ECG tracing. Here, the heart rate was 150 beats per minute, blood pressure response was normal, and ECG tracing showed that left bundle branch block was persistent. Till then, the patient had no symptom, and on repeated query, he replied that he could perform the test. And stage 3 was proceeded. And this is the stage 3 exercise ECG tracing. Here, heart rate was 155 beats per minute. That target heart rate was achieved in the meantime. Blood pressure response was normal. And till then, the ECG findings showed left bundle branch block, and patient had no complaint. Should we go for stage 4? But we proceeded for stage 4 exercise, and the stage 4 exercise tracing was it. Heart rate was 166 beats per minute. Blood pressure response was normal, and patient felt only fatigue, and the ECG showed same findings. And the recovery stage, ECG tracing of recovery at 2 minutes, persisted left bundle branch block, and at the recovery 6 minutes, still persisted left bundle branch block, and the report was prepared as good exercise capacity, normal chronotropic and hemodynamic response, target heart rate was achieved. The patient developed left bundle branch block at early phase of exercise, which persisted up to 0.6 minutes of recovery. However, there was no symptom. And in conclusion, it was inconclusive, the test for evidence of exercise-inducible myocardial ischemia. Many questions were raised in the ETT laboratory. Was this exercise-induced left bundle branch block associated with MI? In absence of chest pain, how could it be diagnosed? Could Garbusa criteria help to diagnose MI here? And what is the Garbusa criteria? Garbusa criteria is the diagnostic criteria for acute myocardial infarction in presence of left bundle branch block, where it says that ST segment elevation in at least 1 liter of more than 1 millimeter concordant to positive QRS complexes will give 5 points. ST segment depression of more than or equal to 1 millimeter in V1 to V3 will get 3 points. And ST segment elevation in at least 1 liter of more than 5 millimeter discordant to negative QRS complexes will get 2 points. And in result, if it is equal to or more than 3 points, is suggestive of acute myocardial infarction in presence of left bundle branch block without the need for further investigations. But is it applicable in exercise-induced such type of left bundle branch block? And particularly in this case, with the Garbusa criteria, we found that no ST segment concordant to positive leads, no ST depression in V1 to V3, and no ST elevation of more than 5 millimeter in any leads. So that criteria does not fulfill the establishment of acute MI in this patient. And we followed up this patient for next 24 hours to assess any symptom. He developed no symptom. 2 blood samples for cardiac troponin I was measured in the laboratory after 4 hours and 6 hours apart, and both the samples are negative. He underwent for coronary angiogram after a few days and was diagnosed as a case of double vessel coronary artery disease involving left anterior descending artery and left circumflex artery, followed by percutaneous coronary intervention, and his ECG became normal. So my take-home message with this presentation is careful reading of an ECG is always important, even in focusing the correctly placed limb leads in the ECG laboratory.
Okay. Can we go back, please?
Yes, sir.
Let's discuss this last case.
Okay, sir. Thank you, sir.
And then you can come to your conclusion.
Okay, sir.
Anybody, any comment on the treadmill stress test?
3 questions. How common is the exercise-induced LBBB pattern? Number 1. Number 2, which pattern we actually see tachycardia-related conduction block? Number 3, should we be concerned more? Should we be go on? As here, the patient was asymptomatic, they have gone on doing the stage 2, stage 3. Should we do it? And is there any problem if we do it? Sir, would you please answer this?
I have a couple of comments also. One thing is that definitely we see sometimes exercise-induced left bundle branch block. Definitely, but also we need to keep in mind some of the other form of tachycardia, Rbot tachycardia, also another you need to keep in mind. But the one point I'd like to make in this case that yes, exercise-induced tachycardia, look at the resting heart rate, what he was in normal, QRS morphology at that time. And when he continued, definitely with exercise-induced tachycardia happened. But when he rested, recovery phase, even with that resting heart rate, he persisted with left bundle branch block. So that is the concern that you should not ignore. Because if, as for example, like patient starting like with resting heart rate 70 or something, and with 110, 120, developing left bundle branch block, then when you recover the patient, then most likely if it's normal phenomenon, then his heart rate when it goes below 120, like 100, then he will quickly reverse to normal QRS complex. He did not reverse in this case. He stayed in left bundle branch block in resting, when in the recovery phase. That alerts me seriously, serious concern. That patient needs to be investigated more for underlying coronary artery disease.
Hafiz, Asif? No. Okay, two things. One, I assume this was a regular treadmill stress test, right?
Yes,
not
sir.
a nuclear. Okay. So this clearly is a rate-related left bundle branch block. The problem is that by continuing this test, we would not have achieved anything, because even if the QRS became normal, there will be some repolarization abnormality which will make these treadmill stresses useless for it. However, if it were a nuclear stress test, definitely I would complete the test. Once the patient develops left bundle, continuing a regular treadmill stress test, from the treadmill stress test standpoint, it is no good at all. So that's number one. Number two, if you take patients with left bundle branch block and when you do exercise, the ST segment becomes ineffective in using the Rbot criteria, because that can be changed in ST segment without definitive ischemia. It should all be decided by the clinical symptom of the patient. And of course, if somebody develops left bundle with acute MI, not the ECG, patient will tell you. We have seen patients developing acute MI on treadmill, and patients get very sick. They develop chest pain, blood pressure drops. So those kind of things did not happen. So, but I'm glad that you if you look at the ECG here, the one that we are seeing, for the audience, lead 1 looks typical left bundle, lead V6 doesn't, but lead V1, V2, initial R is narrow. So that's very much consistent with left bundle branch block. Regarding the persistence of left bundle branch block, this is a thing. What happens, there is a phenomena called linking phenomena. What it means that at whatever rate you develop left bundle doesn't mean that if you reach that rate, left bundle will go all the way. Why? Because the electricity doesn't conduct through the left bundle, comes down through the right bundle, and then penetrates retrogradely into the left bundle. And that makes the left bundle more refractory. So that linking phenomena, so it will take a little bit longer time. Or if there's a PVC from the right side, that will stop that cycle of that. But this is a good ECG. It's interesting ECG, and you carefully thought about it. One of the reasons to continue the stress test would have been to see what is the exercise ability of the patient. That's about it. But the clinical scenario, why did you cath the person? Why did you do cardiac catheterization on this person?
To rule out the coronary artery disease.
Based on what?
Patient has got some chest discomfort for which he was advised for ETT. As the ETT was inconclusive, so we went for coronary angiogram.
Okay, great. Yeah. So the reason I'm asking this.
Sir, can I ask a question?
Yeah, please.
When it is a exercise-induced, tachycardia-induced LBBB pattern, Is it
Yes.
more likely related to coronary artery disease? Because when we see the RBP pattern, tachycardia associated, sometimes we do not see any coronary artery disease on those patients.
Yeah, the question is, aberration is more common with the right bundle. That is absolutely true. But left bundle is not uncommon. So I think it is, the whole point is the clinical scenario of the patient. I mean, patient's family history, what are the pattern of the chest pain? That's important. So we carefully take this history. I mean, we ask them what kind of thing brings the chest pain in. The moment patient will tell me what chest pain, we ask what provokes it. Number two, we always ask, the same activity, does it make the pain happen every time you do the similar amount of activity? So those careful history is very, very important. This is good old clinical medicine. So this is a good case. Thank you.
Thank you, sir.
I came late, but I just wanted a quick question. The baseline EKG was not left bundle, right?
No.
No, sir. No, sir.
So then with the exercise, there was a left bundle. So rate related, but did it come back after the exercise stopped? It came back to sinus?
No.
Or it remained left bundle?
Remain everyone.
It remained left bundle.
That this showed us.
So Rafique, what is the explanation for that?
Well, Hafiz, both can happen. I mean, it can take a little while to recover because as I was explaining that the onset of left bundle, let's say if it happens at rate 90 beats per minute, it does not necessarily mean that it will go back to normal once the rate drops to below 90. Well, I mean, I'm sure ischemia in this case played a role. I mean, as Aziz mentioned, I mean, this is the whole point that one can be linking phenomena causing it persistence a little bit, but or other question is, was there ischemia that was causing the left bundle to become? But you also have to be careful that to become a left bundle system conduction problem, you have to influence the septal perforator area.
One point I like to make in this.
Wadud, one thing I want to mention that could we extend the recovery phase up to 8 minutes to see whether it comes back in this?
We should have done that. Yes.
Yes. Yes.
And one point I like to make that what happens in reality, because this type of patient, and I'm always here, the physician should be, beside the patient. Sometimes I don't rely on the blood pressure taking by the technician. I do it myself. Because if you see any blood pressure drop from baseline, then you get alerted. Because sometimes, technicians just automatically writing some numbers, you might not rely on that. So be extra careful in this type of situation.
But in general, if this is because of ischemia, this will be a declared very florid presentation.
Yes.
Like patient will be sweaty, diaphragm. This is a big deal if it is really ischemia related left bundle.
But Hafiz, this patient had 2 vessel coronary artery disease by cath.
Was that?
Yes, patient had 2 vessel coronary artery disease.
Including LAD?
What is that? Can we go back to the cath report?
Yeah.
No, but
we can go.
Yes, sir.
Yeah, so interesting. I mean, he did not have any chest pain. I mean, the question is,
yes,
how did you ask? Other thing is that we ask for chest pain, but I ask for, is your chest perfectly? Do you feel anything funny?
No, Rafique bhai, where is the film? What is it? How bad was the cath?
That's also important.
Yeah, because
Sharadindu, can you tell us what the condition of the LAD?
It was significant coronary artery stenosis in LAD, but not so diffuse lesion, and there was stenting done in LAD and LCX.
But what is the percent stenosis?
The 80%, near about 80%, sir. 80% stenosis at LAD, and LCX it was also 80 to 90%. And in the distal portion, sir. Mid LCX and mid to distal portion in LCX.
Good. Interesting case. Thank you.
Sir.
Nice
So in my take-home essays, I would like to say that careful reading of an ECG is always important, even in focusing the correctly placed limb leads in the ECG laboratory. And in prolonged QT interval, corrected QT should be calculated for interpretation, and standardization should be looked carefully in all leads in commenting any ECG waves. And exercise-induced transient left bundle branch block is infrequent and occurs in 0.4% to 0.5% of patients undergoing exercise tolerance test. So thank you, sir. Thank you very much for patient sharing.
Nice ECGs. Very interesting and very practical.
So one question I have, Rafique sir, that you mentioned that if we could have done like nuclear stress test on this patient, as for example, right? But routine treadmill to continue, it will not be diagnostic anyway because left bundle branch block. But question, if it's nuclear stress test, and I read a lot of those, we see left bundle branch block induced, perfusion abnormality. Then it becomes a little bit, sometimes you have to be, you have to take all things into consideration to interpret that. Echocardiogram, if you could do that, you see wall motion problem, definitely there will be some septal paradoxical moment with the left bundle branch block itself. But if there's a LAD territory, anterior wall, lateral wall motion problem at the peak, maybe that would be the best option, in this patient. But nuclear imaging studies would have been helpful. But in that case, just continuing walking treadmill is not going to be helpful unless the patient has symptoms.
Yeah, definitely. Thank you.
That is for baseline left bundle, right?
Yeah, but he already developed left bundle branch block. To continue that, if the patient, as for example, just routine treatment, because what happened, patient did not have symptoms, they continued further, next level, third level, fourth level. My question right now, just routine treadmill, unless they have symptoms, would be important. Blood pressure drop would be important, but we cannot definitely do any inference just on the ECG findings alone. That's the reason it was thought to be non-diagnostic. And I'm not sure whether that pursued you to go for cardiac cath.
But I think what I saw that in the Bruce protocol 1, in the stage 1, suddenly patient went into left bundle, right? So if it is a left, I probably would have stopped there and then think
that's
about.
My question.
Yeah, exactly. I agree with that we stop and then think about whether this resolves. If it does not resolve, then, and it is low exercise tolerance, left bundle, multiple risk factors, pretest probability intermediate, we'll do cath or a CTA.
Yeah, I think that brings Hafiz to this point that let's say if the QRS is normal in this person, throughout and test was negative. Again, we have to use this same pretest probability issue, that what is the pretest probability of coronary artery disease in this person? Because a regular treadmill test have a sensitivity and specificity of about 80%. So we can miss 20% of patients. So we have to, this test, the audience need to look into pretest probability and relationship of this non-invasive tests. And the clinical scenario becomes very, very important in this context. Thank you.
Yes, sir.
Sir, I think this concept of pretest probability is important because we do not pay attention to that. Look at the whole patient. What are the risk factors? How is the presentation? What is the family history? And then think about which test you are going to do.
Wadud, we have been fooled by this. I'm taking little time here because it's important. We have been, pretest probability and Bayes theorem is important. But look at this, oncology people, they don't look at the Bayes theorem for breast carcinoma. They go for breast biopsy and the histological thing, right? So I think in cardiology, we have been fooled by the correct question to address in our mind. What is the question to us? Is it the presence of CAD or is it the presence of hemodynamically significant CAD stenosis?
Yeah.
And the third question is it prognostically significant CAD stenosis? So we sometimes say, do I have coronary artery disease? We cannot tell that by doing stress test. We simply cannot. You may have non-significant stenosis. Second question is hemodynamically significant stenosis. We can be fooled because the stress test, as Rafique Bhai pointed out, is not enough sensitive. And the third question, prognostically significant or not. Even myocardial perfusion can be fooled. And we now know from the ischemia trial that anatomy may be more important, excluding the left main and prox LAD, and that may be helpful. And Europeans, for the first time, if you look at the new guidelines, and I'm so happy, first time they're saying it matters in totality of the whole information. So yes, you can do CTA coronaries first, which in the US, still we are struggling to CTA coronary first. We need to do some kind of a stress test and then go for CTA, not right from the beginning. However, in my setting, when the dialysis patient go for transplant, I actually do the opposite. I convince them that let's do the CTA first. If the calcium score is 0 and no coronary anomaly, that is one of the most powerful tools in cardiology, probably the most powerful tool in prognosis of the patient.
But Ahsan, in dialysis patients, they almost will always have calcium there.
Yeah.
Not true. Not true.
Almost. I said almost always.
Not true, because you will be ending up depending on what are the patients like, you know. And I think we actually published this, Aziz Bhai, that it is not one or the other. It is the information in totality.
No, I agree with that. CT would be helpful to exclude left main and proximal LAD disease. That is very important. That's the ischemia trial showed us. And I think the whole world probably will go to the direction in the future, because in the rest of them, I think there's not as significant as left main and ostial disease. So CT, I agree with that, to order some primary evaluation, but that will be probably in the future, because still we're not getting reimbursed for that here.
I think we want to proceed further.
Sure.
Dr. Shafique, are you going to show us something?
Wadud, I have a question for you.
Sir.
Yeah, I have a question for Hafiz and Wadud. I mean, in Bangladesh, CTA costs about 15,000-20,000
yes.
Dhaka.
That's what I was just going to ask.
Okay, and how much is the cost of CAT?
Dr. Shekhar, please share your slide.
Sir, I'll be answering that. In a government hospital, same, the expenditure is almost same.
Yeah.
But
so
in a private hospital, it's again around 14,000 to 20,000 for CAG, and almost similar expenditure for CT.
Yeah. So
so cost effectiveness in our country is a very important factor.
Yeah. One of the questions I always have, Hafiz, somehow I feel that there is a fantastic role for this CT angiography in selected group of patients. And CAT is more definitive answer to all the questions that we are trying to answer. So I think.
So Rafique Bhai, of course, and Wadud will agree with me that radial approach diagnostic CAT elective, the complication rate is extremely low. But my question is, what is our question for the patient? Are we really thinking about significant CAD, or sometimes we want to know whether I want to intensify statin, I want to know whether I have CAD or not. So it's a what is the question first? It's somewhat 40-year-old asymptomatic. I want to convince the wife for statin therapy. I'd rather do a CTA to show that, yes, look at this. You have carcinoma in situ.
Yeah, but what I'm trying to understand is that if you like this kind of patient that we talked about, this particular patient, if we talk about CT angio versus CAT, I think we need to carefully look at this issue of cost benefit and the information ratio. I am a little biased towards cath because I worked in centers where we did a lot of cath, and we found
Wait, this patient I will do cath because
Exactly.
I want because low grade exercise, left bundle, and the question is hemodynamically significant CAD, particularly LAD involvement. Cath, no compromise.
no question about it. So,
sir, we
yeah.
want to proceed. Can Dr.
Yeah,
Shafique
go ahead.
want to?
Okay, sure.
Thank you, sir, for giving me the opportunity. Actually, I'm going to present one case just to learn myself, because it is a very interesting case. Mr. Y, 49 years, car driver, no known risk factors, no family history of heart disease. Taken to ICU of USL, intubated after 20 minutes of resuscitation by CPR at hospital premises in the internal roads, where he's going to pick up his employer from the main gate, and suddenly he went into the garden and car accident, and this is a Range Rover. So this is a serious issue. Then immediately the code blue was called, and code blue went there and given CPR, and patient taken to the ICU. And later on, I was called to see the patients, and I saw the patient unconscious, restless, and previously I got the history from the ICU doctor that patient developed polymetric VT, and then ventricular fibrillation and DC cardioversion. As DC shock was given to defibrillate and reverted to sinus rhythm. Still patient is, and I got the, when I was there, I got the troponin report at this time, and it was 26 nanogram per liter. I did the echocardiogram, that is almost normal. And what could be the diagnosis of this patient? Is it a stroke, hemorrhagic, or acute myocardial infarction with arrhythmia resuscitated, or resuscitated sudden cardiac death? So we can take a poll.
Review, start a poll.
Yes, sir. Kamal, please start the poll.
So
Hafiz bhai, you are there. I know.
No. I mean,
it is for your case.
Chicken egg. মানে আগে conscious এটা কি কোন
Sir,
ধারণা আছে?
yes, that is the point. That is why I am asking you over here. I know. That is why beyond and basics.
So clinical scenario কি অবস্থা, ECG কি অবস্থা, এগুলো তো জানার দরকার।
Actually, that is beyond and basics. That is why I given the scenario and asking the diagnosis. Later I will went to the basics.
Okay.
And that is my heading was that the ECG beyond and basics. And definitely I am going to get to Hafiz bhai's comment, in fact, and I got it. That was my intention as well.
We want more answers.
Very good answers. Definitely, it's a very good answers. But this is a ECG class, so stroke is beyond imagination. But still, this is a very good answer. And we did the. I got the ECG in the ICU.
Dr. Shafique.
Yes, sir.
So 2% answered stroke, and we need to respond to that first.
Okay, sir.
Yes.
What is your comment about it?
Okay, sir. Yes, it could be because patient was found in the car unconscious and having no pulse, no blood pressure, just stand still, and immediately CPR started. Then patient was taken to ICU, and we got the ECG sinus rhythm in the monitor, and later on patient again developed ventricular polymorphic ventricular tachycardia and ventricular fibrillation. So it excludes stroke. So this is
Shafique, can I go through the whole thing?
Sure.
The point is, by definition, a stroke is a localized lesion. you are very unlikely to become unconscious unless you have massive stroke and involving the brainstem. The second is, and the patient have almost normal, the patient had high tropi that can be related to CPR or DC shock, fibrillatory shock.
That could be correct.
So that could be related to the AMI, but you were saying almost normal ECG. And
No, not I am saying. I did not say it is almost normal. ECG is sinus.
Sinus, all right.
Right.
And
There
there
was
was
so it is whether there is any source of
an
inflammation.
AMI suddenly, if it occurs, unless it's associated with arrhythmia, very unlikely the patient would lose consciousness and have such an accident. He's
Patient
very
got-
likely to get stop the car and
Right.
ask for help. So
So
the last one actually
please?
become the answer, because you have resuscitated him from past BP, no, nothing was there. So it was sudden cardiac death and we have resuscitated it. The point is whether it was associated with AMI.
Correct.
So,
Thank you.
so one comment I wanted to make, because we have the level 1 trauma, and we always ask the question, what is the first rhythm and what is chicken or the egg, if they can get the history. If it is a systole or PEA, that's one thing. But if it is a VFib arrest, first rhythm, VFib, that makes us worried that whether the initiation is the arrhythmia causing losing the consciousness. And high on the list will be coronaries. And here, 26,000 with the new assay, it is way higher than non-MI related troponin.
Yes.
Or trauma-related troponin. Usually these are 5,000 or less, usually, but there can be exceptions. Any other concurrent issue, such as head injury, subarachnoid hemorrhage, subdural, or sequential issue is important. Any sequence that will determine the course of the patient, what we do. In case head injury and subdural, then all bets off. But echo is normal. Sometimes we see Takasuru in this situation. So I think we'll have to do a working diagnosis and see how it evolves.
Thank you, sir.
Rafique, can you show the ECG again, please?
No, I did not show the ECG yet. I'm going to show the ECG right now.
Let's continue.
This is the ECG I got in the ICU. So this is the ECG. And should I take the patient to the cath lab immediately? This is another question.
Yeah, we can see what's going on with him. V2, V1, V2.
Yeah.
How
the ST looks like.
Should I take the patient to the cath lab immediately? That is the question. And the ICU people forced me to take the patient to the cath lab to do possible revascularization immediately. They diagnosed as a ST elevation myocardial infarction because there is a ST elevation in V1 and V2. They are forcing me to add it down.
Does he have any family history?
No family history, no family history of heart disease, no sudden cardiac death in his family. And patient is non-smoker, non-diabetic, non-hypertensive.
We'd like to know what medication he was taking, any fever, anything going on.
No positive history, no fever, no drug. He's not taking any sorts of drug, and his electrolytes was normal, creatinine was normal, so nothing else there.
I know what you're thinking, Aziz bhai, but before get to Rafique bhai, you need me.
Okay.
Yes.
Should I proceed next? Next slide, sir.
Oh,
The
not
next
skip
day,
it. Yeah.
next day, so his troponin came down to 11,000. From 26,000 to 11,000 next day. Patient consciousness, gained consciousness in the late night, and patient was extubated on the next day at around 12 o'clock noon. Extubated. And ECG still, this is the ECG on the next day. So
What is sinus tachycardia?
Can we go back to the other ECG?
Previous ECG, sir?
Yeah.
We need Rafique here.
Okay. So the question is, at this point, we have to make a decision. I mean, we don't have the second ECG yet.
Right.
What
Sir.
to do with this patient?
But sir, seeing this
Hafiz,
ECG, I defer to take the patient to cath lab.
Okay.
I mean,
Hafiz?
it can be Brugada type 1,
Right.
but the question is the troponin 26,000 and the echo normal, that makes me think more that this is Brugada, and there could be CPR related, you know, who knows? Likely chance that this is acute PE is unlikely in this case. So this will be my top 3 differential. But I think at the end of the day, we probably would need a cath to exclude and then put an ICD. If the patient has meaningful, if the patient, another important thing, if the patient has meaningful neurological recovery. Sometimes we have unconscious patient and Glasgow Coma Scale 3, and the team is asking for ICD. I said, come on, guys, there is a futility of care. But if there is a good neurological outcome, then yeah.
Okay, Hafiz, my question is, you have this ECG, patient is intubated but awake, can move all extremities.
Yeah.
Not having chest pain, troponin high 26,000. Will you take the patient to the cath lab today or tomorrow?
There is no urgency here, because he's in the control setting, and it is not, I'm not selling it as a STEMI because it does not have the STEMI feature, but we need to look at this because of the troponin is clinically little conflicting. It doesn't match. But by all means, Brugada can explain the whole thing.
Yeah. So one of the things that we have to look at, if you look at the T wave in V1, V2, V3, and the QT interval, in ischemia, you would expect the QT to prolong a little bit more. But this QT is relatively on the shorter side. Brugada has short QT, little bit shorter or normal QT. So it's an interesting case. And so as Hafiz mentioned, you can go both ways. A lot of places will take the, but if the patient is not having chest pain, patient stable, only concerning part of that huge rise in troponin is a little concerning. Okay, thank you.
So in the next day, it was a patient was extubated, and we have to discharge the patient with response because the patient's party has actually they are poor and they are not able. We counsel the patient to implant a ICD, but patient denied. But in the 4th day, patient discharged with response, and with this is here there is no signs of Brugada in the ECG.
Yeah.
So that's my concern. There should be some history we can get from the patient. What precipitated to go to Brugada pattern of the ECG? Because there should be some underlying either medication or something that's causing, or fever that was talking about that might have precipitated that. So we should probably, get a little more involved with the patients to listen to him and see if anything that he has been taking any medications over the counter or anything, new medications. I'm not sure, because definitely somebody precipitated that ECG.
Actually, we asked, interrogated several times to the patient, but he is not getting any sorts of medications and don't have any family background or history. Mm-hmm. This is the first episode in his life. Thank you, sir.
Sir, there's an interesting question came up in the chat box that if this patient has undergone CAG and somehow find that 80% stenosis in the proximal LAD, then with this ECG and normalization, what would be our approach? This Brugada type conversion and then again normal, what would be our approach? Rafique sir.
Well, I mean, we always get theoretical questions. Theoretical questions, we can just make it up. I will still consider that LAD finding as an incidental finding, not the real finding for this particular case. And this, I mean, with this relatively short-looking QT, shoulder down ST segment as Hafiz describes, and you all interventional guys describe it, and a cardiac arrest, and the ECG normalized, and a lot of Brugada syndrome patients can have intermittent ST even with provocation. I mean, provocation fever or some kind of drugs can provoke it, but that's not always true. So this is clearly the Brugada syndrome, and it will be an isolated finding of LAD. That is not going to solve. This patient is going survival rate for next 1 year without an ICD will be close to 0%.
So another question I have, a question right now, the rhythm that he had, that's another recurrence in the ICU setting. It was polymorphic VT, right? Is that correct? Polymorphic.
Right.
Yeah,
that was not documented. That could not be documented.
Could not be documented, but somebody saw it, right, on the monitor.
Right. Somebody saw it, and later on it degenerated to ventricular fibrillation as well.
Yeah, the reason is, in ischemic VT, normally, most of the time it's monomorphic. So that's another point I'd like to make. Okay.
So, for defibrillator use, this patient is the most cost-effective defibrillator use for the nation, because this is a young, active person who has otherwise healthy heart, probably will have normal coronary arteries. And this is a much better patient to put a defibrillator in rather than putting defibrillator in EF of 10% in 100 patients, because those patients are going to die from pump failure anyway. So this is a group that would have benefited most from a defibrillator implantation. Thank you. This is a good case. I mean, you don't always see patients like this, because we see a lot of Brugada ECGs. A lot of them don't have any history of syncope, pre-syncope, but this is a fantastic case. Thank you.
Rafique bhai, rogi ki chole geche financer karone?
Rogi chole geche আমরা ওকে কাউন্সেলিং করেছি, ওরা বলে যে টাকা পয়সা জোগাড় করে পরে আসবে। অ্যাকচুয়ালি ওর এমপ্লয়ার সে প্রথমে বলেছিল সে কিছু টাকা দেবে, কিন্তু লেটার অন দে রিফিউজ টু গিভ দ্যাট মানি, এবং পেশেন্ট বলছে যে ওরা টাকা পয়সা জোগাড় করে। আমরা কাউন্সেলিং ভালোভাবে করেছি এবং পেশেন্ট বলছে এস্টিমেট করে দিয়েছে যে এত টাকা লাগতে পারে, ওরা আসবে বলছে উইদিন মান্থ।
How much is the cost of this ICD in Bangladesh right now?
Single chamber around 5 lakhs, 5
এবং হসপিটাল কস্ট ইউনাইটেড এ আরো 2 লাখ নাকি?
1 lakh.
1 lakh হসপিটাল কস্ট।
Hospital
6 lakh, 6 lakh.
Around 6 lakhs.
Thank you, Shafique. You have shown us a beautiful case. Sir, Rafique sir, are you going to show us some interesting case?
Hafiz
bhai. Oh yes. We are going to you are going to serve us the dessert.
This is the problem I have. Let me see. Share screen. Okay, good. Can you see my screen?
No, not yet.
Okay, so
সমুদ্র 13 নদী পার হয়ে আসবে তো একটু সময় লাগতেছে।
I have this problem from before also. Can you see my screen now?
Not yet.
Why can't I load it? Share.
As you can leave and come again, then it might happen.
Okay, yeah, that's a good point. Okay. Okay, I got it. Okay, good. So, and I think Rafique bhai can stay. So I have few things for Rafique bhai actually. So,
হাফিজ ভাই একটু বড় করে দেন।
Can you see it now?
আপনার the whole.
Okay, so it is a part. Can you see it now?
Yeah.
Yes.
Okay, so Rafique bhai's question. So 29-year male with recurrent syncope, sudden cardiac death in the family. Grandfather at around age 30 died suddenly. And the ER called us saying that, is this a type 2 or type 3 Brugada or type 1 Brugada? And then one of the ER resident called it STEMI so that cardiology can come and see quickly. So what do you think? Your options are in the following: Brugada syndrome type 3 possible, Brugada type 1 with significant family history, Brugada type 2 with definitely because of given history. I am not doing this for exam purposes. So the options I'm telling you is options given to me by my advisors when I was going to see the patient, my fellows and residents, and they are throwing things. So I just threw those things to you. The last one is, it is trash. I'm not going to pay attention, but I did not put that. Shafiq bhai, you are enjoying this? It is back to back your case.
Right.
I don't know, Rafique bhai left. So
No, I'm here.
B is type 2 definite given history. Which one, Rafique bhai, you think you'll accept?
Well, I mean, the pattern itself, pattern is type 3. Because type 1 and type 2, type 1 was what Dr. Shafiq showed the ECG.
Right, sir.
And these are difficult patients. Is it what kind of ethnicity is the person?
Okay, so ethnicity is such that maybe you and Aziz bhai will see that in the CNN they give advertisement 23andMe, that you know 1/4 Vietnamese and 1/4 is Caucasian and half. So that kind of thing, is a mixed ratio.
Yeah. So patient, I saw one patient a few days ago. This was a 23-year-old girl, recurrent history of syncope with seizure, and then presented to the hospital with classic type 1 Brugada ECG without any provocation, and got an ICD in. We are still waiting to see what happens with this. That patient, but this patient has family history of sudden death. Definitely, I mean, we'll have to consider Brugada. The question would be genetic testing, because the criteria are fairly vague. There is no role of EP study in identifying these patients.
Yeah.
And that's a problem. And then you have to do gene testing. And if genetics shows something, then you have to seriously discuss about the role of defibrillator. Unfortunately, the previous patient was a lucky patient that got resuscitated. Most of them will die when they have cardiac arrest, unfortunately.
So our plan is to look into further. You agree that they are going to induce and then see whether it goes into type 1 and then give ICD?
Well, yes. So the other question would be that if we do drug provocation, and there is a European society scoring system, and based on the score, we implant ICDs. We'll yet to have to find out what happens with those patients long term, because in US,
go ahead.
In America, in US, Brugada, we don't have a lot of Brugada. Probably it's more in Southeast Asian countries than over here. Go ahead, Hafiz.
So this is I'm showing you the EKGs from Friday night until now. Whatever I call it, the fresh fish, So this is one of them. So the patient sent home and follow up with EP, and that is the plan with the EP. Echo is normal. The saddleback with right bundle type, if it is more than 2 mm ST elevation, then type 2. But if it is less than that, you can call it type 3. I don't know how strictly you follow that, but the type 1 was what Dr. Shafique Bhai showed you. But this is not type 1. So this is an interesting issue. Young patient with this EKG came in with some sensation of nausea, and in the COVID time, not feeling well, tested negative, and the ER saying, should we admit the patient or should we send the patient home? It's like, I think a young patient, 30s. I think in the last case, Rafique Bhai will agree that whoever said type 2 Brugada or type 3, I think we'll accept both as correct answer, but not type 1. Yeah.
Definitely.
Yeah.
But that ECG was more consistent with type 2, isn't it, sir?
Yes. Or you.
But I would be asking whether, sir, in case
Yeah.
of Brugada, the syncope with type 3 is mostly with during sleep, isn't it?
Yes, that is true. They had at night. Majority of them. The problem
So
of
this is very good, Rafique Bhai. So what is, you want to make any comment, Rafique Bhai?
Yes, good answer. Good answer.
Good answer.
I think this ECG is Wadud's ECG. One of the things you did not mention in this about the ST segment.
Yeah.
And this is Wadud's ECG. I mean, rhythm is okay, but the question is why? What is happening with the ST segment? And Wadud can comment on that.
Yeah, two things are important in this ECG. One thing is that you have P wave seen in lead 1 upright, but you do not see any P wave in lead 2, and there is an inverted P wave in front of QS complex in lead 3. That means it's not from the sinus node. And so the ectopic atrial rhythm is, of course, correct. If it were junctional, I would have expected the PI interval would be more narrow. But look at the QS complex, the classical early repolarization with a small J wave in there. So sometimes people, if they have some sort of chest pain, they mistake it for hyperacute MI and proceed for cath or thrombolysis. That can happen.
It's early repol, and we see that more commonly in African American population.
Also common in our country. We see a lot of patients like this.
Yes, sir. The problem happens when this type of ECG comes with the patient aged around 50 or more, male patient in our country.
Yeah.
Most of the time, we have only ECG in our front, except the patient. Patient is not in front of us. So we have to report the ECG, and that creates the confusion. 50 or 60-year-old male with this type of ECG change.
Tushar, can I help you? Now look at the ST elevation. It's from V2 to V6 in there, but also ST elevation in lead to 3 IVF. MI is a localized phenomena, localized vascular phenomena. So it's not consistent. So we should think of other diagnosis. That's a clue that can help you.
And one more, Wadud, you mentioned about the J point. If you can look in lead V4, V5, V6, and also the ratio of the ST segment elevation and T wave.
Yeah.
That is important. That will be the clue of different. And of course, the patient, when I see this ECG, I will comment diffuse ST, consider early repolarization, and then I will add cannot exclude ischemia. I am not going to make any more comment on that. Hafiz, do you agree with that comment?
If you do not know the patient and you want to be safe reporting, then you say consider my injury pattern. and then
Exactly.
differential is they can figure it out. So and this is one of the message that we should give from this forum, that EKG, and look at EKG in totality, EKG basics and beyond. EKG is not the diagnosis. EKG is like any other test, should be interpreted in the clinical context. This patient coming to your office, life is easy, early repo. This patient coming to your clinic, probably easy, but it's the patient coming with sweaty diaphoretic in your emergency room, life is not easy. Then remember what Rafique Bhai said, keep the differential in mind. So there's no harm in it.
I think one point I'd like to make that, if you read that ECG without the patient, normally what I do, I would say that, okay, it is a, ectopic atrial rhythm, early repolarization pattern. But the question, I put it there, clinical correlation is indicated. That phrase, I throw it there. Because the patient having chest pain or something, I don't see any evidence of acute pericarditis there. But, but if there's PR depression or something in leads, then definitely there's a concern there. But I do not see those evidence. But definitely clinical correlation is indicated. That phrase, I throw it there normally.
And one thing in the same line, one thing we get in the ECG, one information we always get. Sometimes we don't get if it is from the trauma. The patient unknown, they say 116 years old, and the name of the patient is thigh stat, for example. They create the name, they create the age. Other than that, generally, and I told you in this case, it is a 29-year-old patient with chest pain. So we should be thinking 3 times that this is not like acute MI, but things can go wrong, because if this patient is 29-year-old but has diabetes since age 10, that patient is not really 29-year-old. Okay.
Can I make a comment on this, Hafiz? One more thing. Am I right to say, if I have that ECG with a 55-year-old sitting in my office without chest pain, normal everything, I should not tell him, you are going to drop dead, go to the emergency room immediately. So we should not scare the hell out of the patient.
But Rafique, funny enough, we have got patient like this sent to ER from the office. And one thing I ask the residents and fellows, I said, you always say 3 questions. Why you are here? Did you have any problem? And who you are? Who you are means comorbidities. And did you have any procedures in the past? And then why you are here? I went to check my insurance to the doctor's office. Okay, that answers the question. So this is another interesting question. So this patient was, maybe I just say that this is a COVID patient, and this EKG. This is one of my favorite. And then STEMI was activated on Friday night. And this is in the east side of the town. And my interventionalist guy, I cover west side, he covers east side. And I told him that, this is the EKG. So what should we do? Inpatient is a problem to mobilize and get cath. Sometimes, take time. So
I think it's not an STEMI. It looks like, more upsloping ST changes, depression there. Tachycardia induced.
So everybody, how many people agree with that? Or will be worried to
me, Hafiz bhai, it seems like it's SVT. No discernible.
No P wave.
But
okay, so
ABR,
one is the rhythm, one is the ST segment. Rafique bhai, for the
ST
rhythm.
segment is upsloping, little depression is there, but these are tachycardia induced.
Is it a junctional rhythm?
It's
Junctional
most likely it's avian archetype.
But look at the V2
It's nodal reentrant tachycardia.
Look
I
at
think
V2.
we can see P wave in V2, V1.
Yeah.
Now Hafiz is coming into the world of imagination.
Imagination. I do not see.
You see, if I mention
I do not
that,
see any fever.
no, I was looking at lead V2 and I said, I am waiting for Hafiz to say it. If you look at V2, there is a hump after the T wave.
Yeah.
I mean, the range is 150, so it can be actual flutter with 2 run, but there is a hump. Probably that's the P wave. Probably sinus tachycardia.
Sinus tachycardia.
Hafiz, I'm successful. I am successful.
I was going to show you another EKG. One of our GI fellow with the palpitation came to the ER. Heart rate exactly 150. My senior fellow saying atrial flutter, let's cardiovert him. And I said, this is the danger of following the rule of 150, because even in sinus tachy, he can be full. He turns out to be COVID positive and sinus tachycardia. So we did not, okay. So we did not give any lytics, and patient was actually very hypoxic, obese patient, not vaccinated. And that evening developed so much hypoxia, they had to intubate him. And this is after the intubation, this sinus tachycardia. We told them to do repeat CT and use contrast to exclude PE also. And I call it shoulder down ST elevation in lead AVR. Please look at the pattern. This is like Burugada type in AVR. And these are usually not STEMI. So, and this is a chest pain with left bundle. Easy. Is it, will you call it a STEMI or will you not call it STEMI? I think everybody in the audience, please answer.
Okay.
Wow. What's wrong? Wadud.
People should be thinking about Garbosum, then it will be helpful.
Yeah.
If you are not thinking like that, then you are in trouble.
Yeah.
Modified Garbosum is very helpful.
Hafiz, right?
Yeah.
Is it new onset LVB or is there any previous available ECG?
No previous available LKG.
Okay.
So with the Garbosa 3, your sensitivity will be low, but your specificity will be high. With Garbosa 1, your sensitivity can be high, but your specificity is low. So most probably, I would probably go for 1. But this is not to test whether you know or you don't know, but something like Garbosa is there and you need to look at the patient. It's not straightforward. That I was trying to say. Take a look at the patient. There is no need to be nervous or anything. You know what to look at. You have the internet, go for Garbosa criteria. And more importantly, look at the patient. If the chest pain is chest pain, then it is not STEM with this EKG. You can reasonably say that. Okay, so I did not give any option.
Go back to previous ECG.
Yeah.
Another thing is that with the previous ECG, if it is MI, the patient is likely to have sinus tachycardia. That is also absent.
Yeah. And then other thing I forgot to mention, if you are in doubt, quietly do a handheld echo. LV function normal with the injury pattern of STEMI, wall motion abnormality will be rare. Intact LV function will be rare. You will get something. If the LV function normal and atypical chest pain, iffy plus iffy, it is more iffy. So I always tell the ER that if you are in doubt, then more doubt and more doubt make it less likely. So Rafique bhai, this EKG one diagnosis, anybody to convince Rafique bhai? Left bundle with no points in favor of Garbosa. The previous one, discordance 5 was 1 point, but here no point for Garbosa.
Yeah.
But what is the rhythm?
Irregular. Fibrillation.
So irregular. I don't see the P wave replaced by fibrillatory wave, but I still think this is probably a fib with left bundle. But I can be a student of EP. I can say a fib. I can say multifocal atrial tachycardia. I can say multiple PSCs, but I think it's most likely a fib. Rafique bhai?
Yeah, I mean, I can't see any P wave clearly. Even I was trying to imagine in the lead to rhythm strip, you can't see it. You have to see a definite pattern to call it. One would be an atrial tachycardia with variable block, but then you will see a pattern. There is no pattern in it at all.
So here is my question. If you don't see it, will you call it a fib or will you, what you will call it, a top diagnosis? You can give a differential, but your top diagnosis.
Oh, if you don't see P wave, you call it atrial fibrillation.
Yeah, we cardioverted, patient becomes sinus.
Yeah.
And then this is the interesting one. This is, first, I will not give you any history of the patient. And can you choose one of the options? This is also from Saturday night. I think it stays in the date, right? What is the date?
Look at PR, look at PR.
It's in the domain of Wadud sir, as Rafique sir says.
And 27 years old.
Yes.
And that is very important because I took the name out for HIPAA reason, but I left the age because, you know, someone was asking about EKG diagnosis. At least we should pay attention to the age. So the good, 75% got it right.
That's very, very nice.
Yeah, good EKG, patient with cellulitis and also fever, 27-year-old. The floor got worried about monitoring of the EKG on the monitor, and they found this. What happened there? So this is interesting one.
Hafiz bhai, can you go back to the previous ECG? Because the youngster should be paying more attention to a particular point.
And yes, we need to describe that ECG a little bit.
Please describe for them why we were laughing.
Okay, go ahead, Wadud.
This one, yeah. Whenever we have widespread ST wave, T wave changes, and it doesn't follow a single artery distribution pattern, please have a look at it here. And here, there is some elevation, but that elevation is in the PR segment. And only one thing actually produces like something like this. And 27-year-old, this is very likely to be pericarditis with these changes.
And you don't get fooled because of the tachycardia. One of the signs of myocarditis is tachycardia. There may be fever. If the troponin comes positive, this is perimyocarditis.
Yeah.
And don't get worried about that.
And also please focus on AVR lead. PR segment is elevated.
Yeah.
That's very diagnostic.
And for the attendees, I want to tell you that PR segment depression and AVR PR segment elevation, the comparison is with the TP segment, the T wave of the previous beat and the P wave of the next beat. That TP segment is your reference line, and the PR is below the TP segment. Then it is PR depression or PR elevation. This is a 61-year-old post-arrest, transferred from a place that was more than 2 hours away. Patient is now alert, awake, oriented. Blood pressure 95/60, heart rate 100. Comorbidities: diabetes, renal insufficiency, history of atrial fibrillation. On aspirin, apixaban, torvastatin, and metoprolol. Platelets are like 98, creatinine 2.8, hemoglobin 8.2. This is actually from our this weekend also. What to do? They call a STEMI by the emergency room physician, and the patient arrived, and the thoughts are the following: EKG real STEMI, EKG of concern. They should have given lytics, and now the patient is here. It's too late to go to the cath lab, and then and I say I'm not on call. So two participants said evaluate first. So what can anyone from that group explain what you will be evaluating at? Or if not, any other comments from faculty? Because we actually did that, that we evaluated first. Post-arrest, sometimes we see this and look at this V2, V3, there may be some ST depression, but this pattern, and then look at the whole multitude of problem. Acidosis, patient who was on metformin despite renal failure, was acidotic and lactate high, and creatinine was elevated. So we did not take to the cath lab. We corrected all this, and then patient may need ischemia workup, but this was really not STEMI. Troponin was elevated, but small troponin. Any thought by anyone that you still have taken to the cath lab? And remember that patient is on apixaban. Apixaban newer oral anticoagulant. We really be careful about giving lytics in those who are fully anticoagulated, and bleeding risk will be high, particularly if the diagnosis is not sure, you know. So
yeah, one of the relative contraindication is the patient if he's on anticoagulation.
Yeah, but you know, people may say you can go radial and get this done. We actually do that if it is a convincingly STEMI. But this patient had a cardiac arrest. We are trying to figure out why he went to cardiac arrest. That is another important. He went into PA and then came back. So acidosis, electrolyte imbalance, all can be. And post-AP, sometimes we see this kind of ST changes, but you need to look in totality. Another STEMI active, I had 7 ST elevation in my activation this last Friday night alone. And we actually did not take any of them because of this confounding problem. And this is the one from another hospital, not my hospital. I was on call, 42-year-old BMI 42, and obese, diabetes, sleep apnea. And the doctor told her to go to the ER because increasing shortness of breath and leg swelling. They thought cellulitis, and they gave fluid, and then got worse in the night. And then patient had chest pressure, and this is the EKG. And a STEMI was activated. And I am the bad luck. I'm in the middle of the night. They are calling me to take to the cath lab. What should I do? Pulmonary edema and treat. Pulmonary edema, but still cath. Cannot cath, give thrombolytics. And then do cath, get echo, and then maybe treat pulmonary congestion.
Yeah.
Any thought? Sinus tachycardia notably, and there is ST segment changes in the precordial leads.
But there are QFs all over already.
Yeah. Yes. And nobody's fortunately going for lytics.
Okay. What is the lytics one? Oh, 3. Oh, nice. Good.
Nice. Nobody's going for that.
Yeah.
Thank you.
So this is, and interestingly, the patient is obese. We cannot, and the take was smart. And this one, I'm sure Aziz Bhai will like. This is the echo. And they did the definitive contrast for LVO pacification. And Aziz Bhai, any comment?
Yeah, it looks like a pattern of Takasubo. Let's go ahead. Because you see vigorous contraction at the basal and dyskinetic apex, anterolateral, like widespread, like apical dyskinesis.
So troponin maximum was 7,400. And we are doing the cath on Monday. We'll let you know.
Okay.
But I did not take to the cath lab. This is not STEMI. I told them this is not STEMI. And this is the one for Rafique Bhai. So interesting. This patient has come with this EKG on the right, and he's like 51 or something. She has been cardioverted 8 times around this city in different hospitals. She claims that. And many times they have tried by injection. And now she came here, and this is the EKG after cardio, after coming back to sinus. My question is, what should we do next with this patient? Continue medical therapy, AV nodal ablation, and put a permanent pacemaker, ablation over 95% success. But before that, what do you think about the rhythm? Is it flatter, or SVT AV NRT, or SVT AV RT, or AFib? I think that is the first question. And the first question is linked with the second question. In the board exam, they always do that. Aziz Bhai, sometimes we see that, right? If you get the first question wrong, the second question will be wrong also.
I'd like you to focus on the end of the QRX complex.
And the other thing I was actually very grateful to the emergency room physician, who happens to be my old resident. I told him, great that you did not call a STEMI. And he smiled at me. I said, of course I will not call it STEMI. But look at the ST elevation in lead ABR and the ST depression precordial leads. He still did not call it a STEMI. Why? So this is good, Rafique bhai. What do you think?
Sorry, I mean, narrow QRS tachycardia, difficult to see P wave. I mean, in lead 2, you can imagine, but there is a lot of baseline artifact also,
Yes,
which
true.
make this imagination. So my primary diagnosis will be AVNRT, and the second will be AVRT. And the choice, I think ablation will be probably more than 95% success rate, if that's the case.
And you agree that of course you agree. I just wanted to highlight to all cardiologists that the AV nodal DNT success rate is very high and it is curative. So we sometimes don't send to EP, but this is one of the things that is cure. It is like cure, right? Rafique bhai, you agree?
Only cure in cardiology is ablation of SVT.
Yeah.
Actually, it's true.
Okay, that's all I have.
Yeah, very true. Very true.
Yes. So it is unfair not to do ablation. Thank you. Thanks, Hafiz.
Hafiz bhai, thank you. We really have a wonderful time with Dr. Sharadindu, Dr. Shafique, and Hafiz bhai, and with all the adda we have had in between us. I hope that at present, most of our audience are actually busy with their exam. They have started their written exam in different MD, FCPS, diploma courses. So we have half the audience that we expect usually. But I hope next week, if they are free, we can again have a larger audience. Still, I myself have learned a lot, particularly from the presentation of Shafique and Sharadindu. And Rafique sir, Hafiz bhai ECG is always entertaining. The scenario, the explanation, and the to and fro discussion between Rafique sir and Hafiz bhai is always enlightening. Thank you, sir. Thank you, everybody.
All right, thank you.
Thank you, sir. Good night. Assalamu alaikum.
Thank you.